So we're going to end the final day by talking about altitude. So just like all before, acute, chronic illnesses. So here are our objectives. Okay, so it's important to know that altitude actually has no effect on your physiology. Just the fact that you are higher or lower in elevation, that's not the issue. What the issue is that you end up with decreasing pressure. Okay, and we refer to this as hypobaria, okay, low barometric pressure. And so what happens is, as we go up, the amount of oxygen that's in our body decreases. And so as we go up in altitude, barometric pressure decreases and the partial pressure decreases. And this is important because it has to do, or it affects pressure gradients. Okay, so just to give you an example, we can look at if we're at sea level, and we can look at if we're about 4,300 meters, which is about 13,000 feet. Now, in the inspired air at sea level, oxygen, the pressure of oxygen is about 149, gets displaced with water and carbon dioxide. So it's about 100 in the alveoli, a little bit less in the arterial blood due to the AaDO2. And the venous blood is 60, okay? And so the gradient we're looking at, the important gradient, is this right here, between the alveoli and the venous blood. So at sea level, we have a gradient of about 63. However, when we go to altitude, and in this case, it's 13,000 feet, our gradient's reduced to 15, okay? Because remember, it's venous blood that comes into the pulmonary capillaries that we diffuse. And so there's a much smaller gradient, which means oxygen moves much slower, which makes it harder for equilibration to occur. Now, if we look on the oxyhemoglobin dissociation curve, there's a couple of things that we can look at. So if we're at 7,300 meters, so we're getting 23,000 feet, we're going to be in the middle of the steep part of the curve. At 4,300 meters, our alveoli, we're here on kind of the shoulder. So at sea level, this is where we're at. And so it's where we're at on the curve, as we've talked about, plays a big role. And so depending on the severity of the altitude or the height, we're going to be at a different part of the curve in our alveoli. Okay? And so the main stress is that you just have less oxygen. If there's less oxygen in the blood, that means you have to work harder to deliver enough oxygen. Okay? To keep it kind of simple, there's a third of the on the top of Mount Everest, there's 1/3 of the atmospheric pressure, which means there's 1/3 of the oxygen on top of Everest that there is at sea level. Now, this is oversimplifying it, but I still think it gets the point across that means to do anything, you have to increase your delivery by threefold. So that would mean your cardiac output, which is 5 at sea level, would have to be 15 on top of Mount Everest just to do nothing, just to rest, just to survive. Okay, and so that's a really big stress. So it should come as no surprise that as we go up in altitude, performance decreases. And really, this is just with endurance or aerobic performance. Anaerobic performance oftentimes actually have increased performance because of the reduced wind resistance. So how does this all work? Well, remember, we sense oxygen in our carotid bodies, and they monitor the pressure of oxygen, okay? When the pressure gets below 100, the ventilation starts to increase. Now, admittedly, ventilation doesn't increase a whole lot when we're below 100. We usually have to get down below 80 or even 60, really get to that shoulder of the curve. But this is the main response to low oxygen. And so what we end up doing is we end up hyperventilating because our CO2 production doesn't change at altitude. That remains constant. And so if we're breathing more, we're getting rid of CO2. And so we can see that from this figure here. So you're actually technically hyperventilating when you go to altitude. As physiologists, we determine if you're hyperventilating by what's going on with your CO2. And so if you're breathing more, if you're breathing so much that your CO2 is declining, you're hyperventilating. And so that's what this figure over to the right is showing. Okay? And we do this by increasing our alveolar ventilation. We're getting more air in and out of our alveoli per minute. And this helps us to increase oxygen and increases that gradient, which makes it even easier to get oxygen into the bloodstream. Now, depending on how severe the altitude is, we may or may not make up that difference, right? So if it's like if we're on top of Everest, we're not going to breathe enough to get our oxygen to be like it is at sea level. So the benefit of this is we increase our saturation of oxygen on the hemoglobin. Remember, that's how we carry most of our oxygen. But it also causes a left shift as well, because by hyperventilating, we're decreasing carbon dioxide. And this makes it so that oxygen and hemoglobin really want to get together. So that's great. Okay, so it increases that oxygen binding to hemoglobin in the lungs. But again, most likely you're not going to be having a saturation that's what it is at sea level. So how does this all affect exercise, cardiac output, that sort of thing? Well, first I want to show you the effect of training. Okay, so notice that cardiac output is the same. Now, I don't have these lines overlapping, and that's just so you can see both of them. But really, these two lines should be right on top of each other, pre-training and post-training, because you have the same oxygen requirement for a given intensity. However, notice that we reach max, we get to a higher intensity, right? So this person's really kind of met their VO2 max at this point, but after we've been trained, or after they've been trained, they can go a little bit higher. Their cardiac output gets higher. So what's this look like with altitude? Okay, so pre-training we've got the same, but notice our cardiac output's actually increased. Okay, however, we also hit our max at a lower intensity. So we're going to say we hit this at 240. Okay, the oxygen requirement is the same for the activity. However, due to the low oxygen, we have to compensate for that by increasing cardiac output. So if I've got low content, but I increase delivery or increase cardiac output, I'll maintain delivery. So what does this mean in words? So at submax exercise, any exercise has a greater cardiac output than it does at sea level, and this is and so we end up having a higher relative intensity. So this is occurring because we're at a higher heart rate than normal. Okay, altitude doesn't change maximal cardiac output, but it occurs earlier, and so we're not able to go as long. Consequently, our VO2 max decreases. All right, and so this also ties into that relative stress. So I want to end with a slide, or talk a little bit about a slide that we're going to end up talking about with the next lecture as well. So we've got this slide, and I pulled this right off the internet. I've actually got a book that's got this. I don't understand why the colors got all wonky, but there you go. But right now we're talking about acute responses. So I just want you to focus on this acute phase. And really what I want you to do is I want you to focus on ventilation. So that's this line here. Okay. And don't worry about HIF, but I also want you to focus on cerebral blood flow. Those are really the only two things that are affected by acute exposure to hypoxia. Okay, so when we first get to altitude, our ventilation increases, but shortly thereafter it decreases. Okay, now this first part, this first half, this big spike, that's what we call the HVR, the hypoxic ventilatory response. We're increasing our drive to breathe, or we're increasing our ventilation to try and make up for that lost oxygen. But notice what happens shortly after. We actually have a decline in ventilation. Now we start down here at 0%. That's just give us an idea. So we drop maybe 50%. Okay, so what's causing this? Why would, after 10, 15 minutes of hypoxic exposure, start to decrease our ventilation? And the answer is we're actually turning off one of the drives to breathe. When we get to, when we're here at sea level, the reason you're breathing is because of high CO2. You're producing CO2, but it's not really an oxygen thing. However, when you go to altitude, you still have that CO2, but now you have low oxygen. However, when you hyperventilate, you're getting rid of the CO2, and so as a result, that drive to breathe is reduced. This is also tied in with this decreased cerebral blood flow. When we have low carbon dioxide, we actually decrease the amount of blood that goes to our brain. This is why when you hyperventilate, if you hyperventilate long enough, you actually get lightheaded and potentially pass out because you're reducing blood flow to your brain. Your brain senses CO2 and goes, oh, there's not very much CO2 here. I don't need much blood. And down you go. Okay, so just to kind of recap with this figure showing the similar thing. So here we have that hypoxic ventilatory response, right? So we have this sharp increase in ventilation. Ventilation's here. This causes a decrease in CO2. Yes, there are two different sets of units here, so you're familiar with the 40. So we have a decrease in CO2. And what this ends up doing is we increase our ventilation to try and get back up to normal, right? So we're starting here around 90, go to hypoxia, it drops, and we try and get back up to normal, okay? So ventilation can increase up to 4 times, depending on how severe the hypoxia is. Remember, the PO2 of 60 equals a saturation of about 80%. We don't have the curve here. That's the shoulder of the oxyhemoglobin curve, and that's where ventilation really starts to take off. When arterial oxygen drops, ventilation increases. Okay, that ventilation increase stops or apparently it stops is probably the best word for it after about 10, 15, 20, maybe even 30 minutes, called the hypoxic ventilatory decline. However, notice that ventilation increases over time. Okay, and this isn't exactly sure, but this is one of the things that happens as we acclimatize. And so with that, we're going to end.